So as a trauma center, we have the opportunity to visit the upper cervical spine quite frequently. And what I'm going to do is look primarily at posterior C1 and C2 fixation as well as anterior odontoid screw fixation. And what we've wanted to do, because of the fact that we use this type of fixation so frequently, and it's always important, I think, to tell patients or try to give patients the best possible idea what they're getting into, we endeavor to try and find out what our complication rates were when using these techniques, particularly posterior C1 and C2 screws. And so we looked retrospectively. I'm going to go over some of our results here at the results of fixation at the C1 and C2 levels. Why C1 and C2 in particular? Well, it's because they have life-threatening complications there. And I think it's important to be able to explain to the patients and their families ahead of time what the risks really are. And because the profile has changed with regards to available screw techniques, I think that our feeling really was that the historical complication rates were going to be different. You know, back in the day when you had to try and put a transarticular screw in regardless if you really needed that type of stability, our sense was that our complication rate had actually become lower because of the advances in types of instrumentation, type of fixation that was available. So in particular, we looked at neurological and vascular risks. And so we evaluated a large series of patients, both posterior and C1 and C2 screws, to determine the accuracy of screw placement as well as the associated complication rates. And the hypothesis, as I just mentioned, is that overall C1 and C2 fixation techniques are actually pretty darn safe and accurate, though obviously not entirely so, and that the safety of these techniques has actually improved over time, in all likelihood due to the increased options, though that's obviously a very difficult hypothesis to prove, the second one. So I'm going to start with the C1 screw fixation. I'll go into a little more detail with this one. The C2 is a similarly designed study, and I'll just really talk about the results. So we had 176 consecutive patients, 344 screws were placed, and we're talking about any screw that was placed into the C1 lateral mass. So that includes transarticular, so there's a bit of crossover between the studies. As you can see, it includes transarticular screws as well as C1 lateral mass screws. And we basically looked at the complication rate as previously described. From a radiographic standpoint, we looked at the results by classifying our screws into three types. Type 1 was money screw, 100% in cortical bone, or in bone, I should say, the whole way, no concerns whatsoever. Type 3s were screws that were circumferentially, or at least greater than 50% of the circumference of the screw was actually out of bone, as in this bottom screw here, where actually both of the screws are too medial. And these are type 2s, which are generally considered safe and acceptable, but not ideal, where greater than 50% of the threads is within bone. And because we had hybrid constructs, we looked at each screw individually rather than patient-centered outcomes, and we looked at the clinical outcome variables that you see below. Neurovascular complications were really the primary issue that we were looking at. With regards to operative technique was similar with all surgeons involved. Lateral fluoroscopy is the primary visualization tool that we use. There was no navigation used, and I don't know that anybody for C1 screws places them without fluoroscopy on a routine basis. We generally use, there's really three types of starting points. There's the classic Harms or Goel starting point, as you see here, which is on the posterior aspect of the lateral mass below the posterior arch. And then there's the starting point right up on the arch, and that's particularly in patients who have a wider posterior arch. And then I should mention a third one, which is kind of a variation. It's right in between the two, where you take down just a little bit of the inferior aspect of the posterior arch here to elevate your starting point a little bit to get away from the C2 root and the venous plexus and avoid the bleeding that can occur at the venous plexus. And they each have, to some extent, their own complication profile. Obviously, it's extremely important to be familiar with the posterior C1 anatomy and how far you can dissect out, for instance, before you have to worry about the vertebral artery, so 8 millimeters over the top of the ring in general, 12 millimeters more posteriorly on the ring. And here's an example of where the starting points were. You can see 1, 2, and 3 is exactly in between. And so the disadvantage of starting point number 1 is, as you can see illustrated here, is you actually have to retract the C2 nerve root, and really more importantly than that. So first of all, theoretically at least, although we couldn't really identify this in our study, theoretically there's a greater risk of greater occipital neuralgia when placing that screw. But really the more problematic issue is the fact that the venous plexus bleeds to the point that it's a nuisance, and or it can potentially even be a safety issue. And the problem with the more superiorly placed screw, potentially, is the fact that it's closer to the OC1 joint. It's more likely to have OC1 joint penetration. Obviously, there's a potential, if you don't choose your patient wisely as far as the way their anatomy is, they don't have a wide enough ring, there's always a possibility of a vertebral artery injury above the ring. And there's always a possibility of a ponticulus, which is a ring of bone, shell of bone, I should say, which comes posteriorly up above the C1 posterior arch behind the vertebral artery. If that's misinterpreted as being the posterior ring and you drill through that, well, that's going to be an unpleasant surprise. So that's, I guess, a risk to this particular starting point. And personally, I think that the in-between starting point gives you the best of both worlds. So in the end, our results, the accuracy was quite good as we had anticipated. 86% were ideal or type 1 screws, 10% were acceptable screws, so those 96% of screws were considered safe, and we had 4% screws that we considered unacceptable or type 3 screws, again illustrated in this example here. Interestingly, and this is, I think, a statistical anomaly for various reasons, but we found that there was a statistically significant difference with regard to accuracy of transarticular screws versus C1 lateral mass screws. Okay, meaning that transarticular screws were somehow more accurate, and there's probably some selection bias involved there, because with the advent of all the various C2, and now again this is where the studies tend to cross over, the advent of all the various C2 screw placement techniques, you have to understand that transarticular screws now are only placed in the most ideal patient. Right? They're only placed in circumstances where we probably know we can get a perfect screw, as opposed to being able to place other kinds of screws. And that's in direct contrast to, let's say, 10 or 15 years ago, where sometimes you'd kind of try and force that screw, and I think that's when people would get into trouble. Try to force that transarticular screw in a patient that's not ideally suited for it, but in whom you don't have really good options to achieve the type of stability you need. So anyways, I thought that was an interesting finding. And there was no difference between surgeons. These are the different surgeons, screws placed, accuracy rate not statistically different among any of us. So of the 12 unacceptable screws, you see their location. One of them, you can see this was just placed exactly medial to the lateral mass and needed to be repositioned. And no screws, fortunately, were within the vertebral artery foramen. A couple of points when placing these C1 lateral mass screws. Generally speaking, we tend to aim for the anterior arch on a lateral fluoroscopic view. It's important to remember that you don't need to drill as far anteriorly or place a screw as far anteriorly as the anterior arch because of this variable angle that there is in all patients. This is the average. The average is about 21 degrees of angulation, which amounts to about 5.5 to 6 millimeters of distance. So, obviously it depends on the patient's rotation as well, but you will expect that the tip of the screw should be posterior to the projection of the anterior arch on your lateral fluoroscopic view. So that's one important technical point. And why does that matter? Well, the reason it matters is that lying anteriorly to the lateral mass or the hypoglossal nerve, as well as the internal carotid artery. And here's a nice example of the relationship between the internal carotid artery right here and the anterior aspect of the lateral mass and the vertebral artery here. So you can see that that's a structure that's potentially at risk. Clinically, there were no cases of postoperative neurological deficit and no cases of vertebral artery injuries with the C1 group. And you can see that there was one patient in whom there was a suspicion, but ultimately I think probably the exuberant venous plexus bleeding was perhaps misinterpreted as being an arterial injury, as the CTA was negative and the patient did fine. There are a few studies that have come out, this one practically simultaneously with ours, that also had almost identical results. Their assessment was a little bit different, but they ended up with 95% acceptable screws. And so this shows us that C1 screw placement is actually quite safe. And it's actually, if you do a cadaver dissection, the starting point's frighteningly close to the vertebral artery, but it appears that vertebral artery injuries aren't really readily reported or frequently reported with this technique. C2, a little bit different. Still, our results were still quite good. Greater number of screws as you would anticipate. simply because we've been using the technique longer. 98+% accuracy rate. However, we did have 2 vertebral artery injuries with this series. So that's a rate of 0.3% per screw, which is substantially lower than many of the published, certainly in the historical rates of 2% per screw, and a little bit lower than even more recently published lower rates. And again, no neurological injuries either. And to what do we attribute this degree of accuracy? Again, to ensure maximum safety, it's essential, I think we all would agree that it's essential to really delineate the anatomy. I think every one of us really exposes this pars interarticularis, the posterior elements, exposes them to the point where we have an extremely good understanding of the anatomy. This helps us actually decide. We project the starting point based on the extrapolation of where the pedicle, actually this shows it better, where the pedicle is out here and over here, and then we determine the craniocaudal location of the starting point based on a combination of what we're seeing as well as our lateral radiograph. And then we can direct our screw right along the lateral or the medial aspect of the pars and pedicle, just lateral to the canal. And when you have direct visualization, and of course you've scrutinized the CT scans well beforehand, and you realize that you do have an appropriately positioned vertebral artery foramen, then that eliminates much of the risk. The types of screws, this is kind of an interesting slide over time. You can see that the transarticular screws, which are the blue ones, have decreased with time to practically disappear. At least they've leveled off, whereas the pedicle screws have increased considerably. Laminar screws kind of came into, or translaminar screws came into vogue sometime in the mid-decade and have been more or less steady since that point. Vertebral artery anatomy is important to look at, obviously, on the CT scans. I don't think that's news to anybody. And primarily it'll preclude transarticular screw placement in a significant number of patients, but also pedicle screw placement as well. And one thing that I think has helped us diminish our complications with posterior C2 instrumentation is the advent of laminar screws, which I still don't like to use personally as a primary means of C2 fixation, because there are various reasons. It's a little bit more of a fiddle. It doesn't line up and connect quite as well with the rest of the spine. But I have no hesitation to use it if I think that there's a remotely unsafe passage for a pedicle or transarticular screw due to vertebral artery anatomy. And there's pretty much negligible risk to the vertebral artery with placement of this screw, and biomechanical studies have shown rigidity that's equivalent more or less to other constructs as well. And here's just an example. Another reason why you might potentially want to use the translaminar screws is if there's some comminution at the level of the C2 body or lateral mass, since that screw doesn't engage that part of the vertebra. So conclusion with regard to posterior C1 and C2 screw fixation: low complication rates and no cases of neurological deficits at all, a small risk to vertebral artery injury, and this is information, again, that can be potentially useful for patients. Again, our theory is that the increased safety has to do with increased options with regard to screw placement that allows us to tailor the specific screw to the type of patient, their anatomy, their body habitus, et cetera, which wasn't the case 10 or 15 years ago. Thank you very much.
Thank you, Carl. Thanks. Next presentation is by Dr. Fangyi Zhang, and he'll speak about image guidance. Thanks, Fangyi.
Thanks, Mike. Traditionally, we use the direct visualization of the anatomical landmarks in the spine surgery, and then we can use the serial radiographic X-rays. And by modern days, the C-arm fluoroscopy is kind of standard, the intraoperative imaging guidance. Also, you have to be aware about the radiation magnification, the distortion, and the parallax. The intraoperative navigation used to call the frameless sterotaxy, and it's basically provide a three-dimensional visualization of the hidden anatomy in the surgery. And this has been used in neurosurgery extensively, which have reduced both the operative time and also the comorbidities. And the first time it's applied to the spine surgeries by Kalfas back in the 1995, and the standard system that you need for this navigation includes first is a computer workstation, and then a dynamic reference array, which is sometimes called a DRA, attached to the patient. Then you will need a camera to find this the DRA, and then you're going to need a bunch of the LED attached instruments that can be traced by the camera. And the source of the images for the navigation, you can use the preoperative CT scan. Also, you can use the intraoperative CT images, the imaging studies, including the fluoro, sometimes you could call the virtual fluoro, and then you can use the 3D C-arm fluoroscopy, sometimes called ISO-C, and then you can use this intraoperative CT scan. The preoperative CT-based the navigation is that they have two stages. One is before the OR, you scan the patient just in the normal scanner and they use the navigation protocol. Normally it's a SynCut scan. And then you transfer the data into the computer workstation, and then they reformat it and give you a 3D dimensional picture, and then you can plan it before you go to the OR. Now, the disadvantage of using the preoperative CT scan for the navigation, number one is the registration process. This one is very time consuming and have a very steep learning curve. Number two disadvantage is that the patient's position at the CAT scan and during the surgery is different. Therefore, as we know that the spine is a flexible structure, then the intersegmental relation will change. So therefore, sometimes you really have to register each individual the vertebral as you go for the surgery during the surgery. And also, the preoperative CT-based the navigation need the registration of the dorsal surface of the spine. Therefore, you really have to open it to find it and then to match it to the computer system, the imaging. So it's only can used for the open surgery, has almost no use in the minimum invasive procedures. Now, let's look at the intraoperative imaging-based navigation. The first, there's a virtual fluoro. What it is that attach a calibration target to the C-arm head, and then use the DRA attached to the patient and set up the camera, and then you can do navigation. During the procedure, the camera will track the position of your surgical instruments, and on the screen they can display. For instance, if you use the pedicle probe, they can overlap in your actual probe position to the virtual probe position. The advantage of that is doesn't need the registration, doesn't need to open the dorsal spine, so that you can save time in the OR and also can suit for the minimally invasive procedure. The disadvantage obviously is only two-dimensional imaging guidance. They don't have axial image, and also the quality of the imaging is totally depends on the resolution of your C-arm. The obesity and also osteopenia and deformity can hinder your accuracy. And the three-dimensional C-arm is pretty much the same as the two-dimensional C-arm, except he can do like a half circle rotation and then get multiple successive images during this rotation, and then computer can reformat it into a 3D dimension. Now, intraoperative CT, you can have the built-in units in this lavish, the OR suite, or you can have some portable units. One of the portable units that we have to mention is this O-arm system by Medtronic. The first unit was sold in June 2006. There's about roughly 260 units in the United States, about 310 units worldwide. And the unique of this is to provide a lateral patient access, which for the people who use Jackson table for everything, this is the great advantage. And also you can use it as a 2D fluoro as well. When you do this 360 rotation scan, then they can reformat it into a CT-like, but not exactly the CT picture. Just be aware that the scan length of this O-arm is shorter than the regular CT scan. It's about 15 centimeter, which covers like 4 or 5 lumbar vertebrae and then about 6 or 7 cervical vertebrae. And then the O-arm can be coupled with the stealth navigation system, which is neurosurgery. Virtually every neurosurgery department has it. And then you can do the intraoperative navigation because it's using the intraoperative picture. Therefore, you don't have to do the registration. And come with this machine, they have lots of fancy tools like a navigated pedicle access and with the LED attach it, and they also have a navigated tab, have the navigated the screwdriver. And now, come to the bottom line, let's ask this question: why we need all these fancy equipments? I mean, they're expensive. Now, can this really improve the patient's safety? Does this the navigation can really increase the accuracy of the implant placement, or what about the radiation exposure to the patient? Now, for example, the thoracic pedicle screw placement, historically, reported data shows that the pedicle breach is about 8 to 40%. Now, based on my conversation with the surgeons across the country who has the intraoperative navigation access, suggests that the navigation helps to reduce it. Now, this is the publication data to support it, which is this one is used the preoperative CT scan for the registration and the navigation. It shows that the pedicle breach is lowered to 1.8 from compared to the fluoro is 9%. These ones use the ISO-C, which is achieved like 2% of the perforation compared with the 23 in the fluoro group. And these two studies use the intraoperative CT scan. One is built-in units, the other one is use the O-arm, which achieved like 1.6 to 3.2%, which is not bad. So the bottom line is the fluoro, the baseline is about 10 to 40% pedicle breach rate, but the navigation can, fairly consistently provide an accuracy about the 1.6 to 3.2 perforation rate. Now, however, in some early studies, without navigation, they still reported some, the good accuracy. This paper only have 1% in the perforation rate. Then this will lead, the people think that with advanced training, a surgeon can definitely achieve the similar accuracy without the navigation. Let's look at our Harborview study, which was Sohail published in the 2003. We utilized like two most experienced surgeons in our group and compared the four methods of the intraoperative navigation or imaging guidance. We found that using the preoperative CT-based navigation indeed is better than the standard fluoroscopy. However, the accuracy is not that much more, though. And in this paper, we also look into the radiation doses to the patient. We found that by converting to the modern units, the millisievert, the intraoperative CT delivers like the tremendous radiation to the patient compared with using the C-arm for the fluoroscopy during the surgery. Now, any improvement over the years, obviously everybody knows the recent studies shows that the number of the CT scans is proportionate to the lifetime attributable risk of the cancer, so that it's becoming more and more a important issue for both patients and the OR staff. Now, the latest report, the dose report from Medtronic shows that the O-arm system for one scan in the chest area, the small patient is about 2.55 millisievert. For the larger patient is about 3.9. But if you want to look at the detailed soft tissue, the structure, then you have to increase to 6.29. This is pretty much confirmed by independent study in the University of Minnesota, which shows that the O-arm delivers approximately half of radiation dose compared with the standard 64-slice CT scan. But keep in mind, the O-arm scan, the length is less compared with the conventional CT scan. And also there's a publication suggests that the O-arm scan can be tuned down to reduce the radiation without loss of the resolution that's necessary for the navigation. So in summary, the intraoperative imaging guidance and the navigation can improve patients' safety by increasing the confidence in achieving the surgical goals, can confirming the quality of the decompression, extent of the tumor resection, etc. Also can achieving more consistent accuracy of the implant, and potentially can eliminate the unplanned return to the surgery. It may have less radiation exposure in the certain patient population and the procedures compared with the conventional, the fluoro. However, this needs to be studied further, and it does improve the safety for the surgeon and OR staff by avoiding the exposure. But obviously, the machine is not recommended for the routine use. For instance, if you have a short segment procedure, you don't have that much radiation to the patient, then you probably shouldn't use it. And then the conclusion is the intraoperative imaging and the navigation is a wonderful tool, and it may enhance patient safety if you utilize it appropriately. If you decide to get one and the hospital support you to get one, keep this in mind. There's a learning curve to use it, and also it does not replace the advanced training and the experiences. And there's a famous saying everybody knows, a fool with a wonderful tool is still a fool. Thank you.